Good afternoon, everyone. Hopefully you can hear me clearly. If not, please put it in the chat and we will adjust accordingly. Good afternoon. I am Karima Woods, the Commissioner of the Department of Insurance, Securities, and Banking. And I would like to call this hearing on 2022 proposed health insurance rate to order at 5:31 p.m. on Thursday, September 9th, 2021. This hearing is being recorded and will be available on the DISB website, disb.dc.gov. Please mute your line or your computer if you are participating via WebEx whenever you are not speaking. This will help to prevent any background noise from disrupting the meeting and ensure the best sound quality during the call. So thanking you all in advance. I would like to take a moment to set the stage for the hearing by describing our department, the purpose of the hearing, and the district's health insurance rate review and approval process. A little bit about our department. The department regulates financial services industry in the district, which includes insurance, securities, and banking institutions. Our mission is threefold. First, to cultivate a regulatory environment that protects consumers and attracts and retains financial services firms to the district. Second, to empower and educate residents on financial matters. And third, to provide financing for district small businesses. I am joined here today by members of my team, Philip Barlow, who is our Associate Commissioner for Insurance, Andre Beard, who is our Attorney Advisor, and Howard Liebers, our Supervisory Insurance Examiner. We also have Dave Dillon, an actuary from our consulting firm, Lewis & Ellis, who will present information on their review of the 2022 proposed rates. The purpose of today's hearing is to inform the public of the department's process for reviewing and approving health insurance rates, and to receive comments on the 2022 proposed health insurance rates filed by the carriers offering health benefit plans in the individual and small group markets. Small groups are businesses with up to 50 full-time employees. A summary of the proposed 2022 rates, along with their current proposals as a result of our actuarial review, can be found on the department's website at disb.dc.gov. A current snapshot of the proposed rates is also available. Following my comments, Mr. Barlow will provide a brief explanation of how to use the snapshot documents. As for the hearing procedures, we will hear first from Dave Dillon of Lewis & Ellis, as I mentioned earlier. He will be followed by Mary Beth Sinskowitz, Associate General Counsel and Policy Advisor, who is joining us in place of Vila Kaufman from the Health Benefit Exchange, the DC Health Benefit Exchange Authority. Finally, we will hear from those individuals who have signed up prior to the hearing. Then we will hear from anyone present who did not sign up, but who wishes to provide public comment, generally in the order of request. Public comments should be limited to our review process, the proposed rates or recommendations, and issues we should consider as we review the proposed rates. Comments should not address current issues with insurers or rates in effect. Please keep your comments to 3 minutes or less. We want to be able to hear from everyone participating today. If you are participating via WebEx and would like to testify but did not sign up to do so ahead of time, please raise your hand within the chat and we will call upon you to speak later. If you phoned in only, we will ask at the end for anyone who wishes to speak, and please do so at that time. A little bit about the ACA. The Patient Protection and Affordable Care Act, often referred to as the Affordable Care Act, ACA, or Obamacare, is a comprehensive healthcare reform law enacted on March 23, 2010. Its goal was to make affordable health insurance available to more Americans. The district enacted several laws to implement and enforce the ACA. The Reasonable Health Insurance Rate-Making and Reform Amendment Act of 2010 established rate-making principles and standards as additional guidance in reviewing and approving health insurance rate filings. Specifically, the law directs me as commissioner to ensure that health insurance rates or fees are not excessive, inadequate, or unfairly discriminatory. In 2014, the district enacted the Federal Health Reform Implementation and Omnibus Amendment Act of 2014, which codified in district law provisions of the ACA and its implementing regulations. The district passed the Health Benefit Exchange Authority Establishment Act of 2011, which established the District of Columbia Health Benefit Exchange Authority, which we also refer to as HBX. The department regulates health insurers and reviews and approves health insurance rate and form filings for all comprehensive medical products sold in the district. Once the department approves rates for individuals and small group insurance plans, the HBX certifies them as qualified health plans offered for sale in the district through DC HealthLink, which is the district's state-based exchange that allows people to enroll in coverage and manage their health insurance plans. The ACA's major provisions were implemented in 2014. Since then, the district has been a leader in expanding access to affordable health care for our residents and small businesses. Because we leverage the ACA, more than 96% of district residents now have health coverage. And as of 2019, the District of Columbia was second in the country with only 3.6% of the total population projected to be uninsured. Currently, there are more than 16,400 people with private health insurance through the individual marketplace and over 5,000 employer groups offering coverage to more than 80,000 employees and their families through the small business marketplace. Due to expanded coverage changes in response to the COVID-19 pandemic, an additional 1,100 employer groups cover nearly 3,000 more people. Together, more than 100,000 people are covered by the health insurance plans sold on DC HealthLink here in the district. A little bit about the rate review process. The department uses what is known as an effective rate review program. Pursuant to the U.S. Department of Health and Human Services, regulations states, including the district, with effective rate review programs must conduct reviews of proposed rate increases above the applicable threshold, which includes rate increases of 15% or more. Prior to the ACA, annual premium increases in the individual market were highly variable, and increases often averaged 10% or more at the state level. The department's review of rates under the ACA, coupled with several critical protections for consumers who purchase health insurance coverage in the individual and small group markets, have brought new levels of scrutiny and transparency to health insurance rates in those markets. Also, the increased reviews have resulted in some issuers lowering their rates. The increased transparency allows consumers to view rate information that was not previously available. The process starts when an insurance company submits a rate filing request to the department's insurance bureau. The rate filing is assigned to a staff member within the Insurance Bureau's Health Insurance Actuarial Division for review. Due to the complexity of these rate filings, the division also utilizes an actuarial consulting firm to conduct an additional review of the rates and make suggestions and recommendations to the division based on purely actuarial analysis. These employees and consultants are subject matter experts in mathematics and the measurement and management of risk and uncertainty. They review rates based on a variety of rating factors and assumptions to ensure that health plan rates are justified and adequate considering the coverage provided. Reasonable rates should be adequate to cover the cost of paying expected cost of medical claims and operating expenses. The division will recommend changes to the rate filings. Once the Health Actuarial Division determines that the rate request is reasonable, the division recommends to the commissioner that it be approved. Conversely, if the division believes a rate is excessive, inadequate, or unfairly discriminatory, taking into account all relevant factors, including public policy considerations and legal interpretive guidance, which is the legal standard governing the department's rate approval process, it will discuss its findings with the insurer and require changes to the filed rates before the department approves. The department's rate review process resulted in 3 out of the 4 insurers revising their rates down from their initial filings. I review the Insurance Bureau's recommendations along with the comments received from the HBX and public and make a final decision on the rates filed by each insurer. The department expects to finalize the 2022 rates by the middle of September and will post the final approved rates at disb.dc.gov. Now I'll share a little bit about an overview of the current filings. 4 major insurance companies, Aetna, CareFirst Blue Cross Blue Shield, Kaiser Permanente, and United Healthcare, filed health plans offerings for individuals, families, and small businesses on DC HealthLink. Overall, 184 plans were filed compared to 188 last year. The number of small groups plans decreased from 163 to 157, and individual plans increased from 25 to 27. The department's rate review over the last few months has resulted in reducing the insurance company's proposed rate increases by 1.3% on average for individual plans and 1.5% on average for small group plans, with some reducing their proposed rate increases by over 10%. To meet the standard I mentioned earlier, that final approved rates are not excessive, inadequate, or unfairly discriminatory, and to be more transparent for members of the public about how rate increases are reviewed and approved prior to a new plan year. The department improved its rate review process to include public hearings. And I'll also add that as of last year and this year, we enhanced that by providing those public hearings virtually. Before turning to the witnesses, I would like to note that if anyone isn't prepared to speak today or could not otherwise join us this afternoon, written comments also may be submitted until September 15th, 2021. Comments may be submitted by email to healthrate.comments@dc.gov. To date, in addition to the residents scheduled to testify tonight, the department has received a number of written comments. So with that, I will turn things over to Philip Barlow to discuss information about the filed rates. Thank you.
Thank you, Commissioner. I am going to share my screen. And as we do usually, there are a number of pages of summary information that we provide at these hearings. This is the same information that we typically provide. The information is available on our website. I posted a link in the chat so that you can access these pages. The first page is just a summary that indicates the various insurers, the number of plans that they filed for HMOs, PPOs, small groups, and individuals, their initial rate request, what our actuarial review, the results after our actuarial review, the range within, because the changes aren't necessarily uniform, so the range of changes within each filing, and the reported number of covered lives. The next page includes a sample rates. For individual plans, it provides the high, low, and average rates for ages 27, 40, and 55. So it also identifies the number of plans available in each category for the two companies that sell insurance on our individual plans on DC Health Link. Similarly, the next page provides information on the small group, the shop plans. So it breaks out for ages 27, 40, and 55. It breaks out the high, low, and average premiums by PPO and HMO. It also, again, identifies the number of plans in each category. The next sheet looks at the change in rates for plans that existed in both years, since there were a few changes. It looks at the plans that were available in both years. It looks at the changes from the currently reviewed changes from the filings compared to what the rates were last year. And then the final page looks at what the impact of our rate review. So it shows how much the rates have changed from what was originally filed by the carriers. So again, this is the same information that we provide every year, and it's intended to be summary information to kind of give you an idea of what's in the filings as they currently stand with the department. And with that, I will stop sharing my screen and turn it back over to the commission.
Great. So as mentioned in my testimony, we will now hear from Dave Dillon, Senior Vice President and Principal with Lewis and Ellis, who will present a summary of proposed rates. Dave.
Thank you, Commissioner. Appreciate the opportunity to discuss LNE's actuarial review of this year's health insurance filings. This is LNE's 7th year of reviewing ACA filings for the DISB, and we've reviewed over 70 filings since 2016. And I should also mention, in addition to the DISB, LNE is currently assisting 14 states with ACA-related rate reviews. One thing we've learned is that every jurisdiction has their own nuances, and so we definitely take that into consideration. For example, DC has what we would call a semi-merged market, which was established to help stabilize premiums in the individual market. So we'll take that into consideration. We also review for compliance with all of districts' laws and regulations, federal law and regulations around the ACA, and actuarial standards of practice, which we call ASOPs. There's specific rules the actuaries for the insurers must follow to develop the premiums. The primary point of the review is determining the reasonableness of each specific assumption and the aggregate assumptions. Make sure everything kind of makes sense in the development of the rate increase. So once we review the reasonableness of those assumptions, we can then make recommendations to the department whether the proposed rates are not excessive, inadequate, or unfairly discriminatory. And here are those words again that the commissioner mentioned earlier. And I should clarify that those are actuarially defined terms. And those are in the actuarial standards. So when L&E performs a review, we have two credentialed actuaries that perform a review. We have one that's a lead actuary that's worked on each insurer's filings over the years, so they're very familiar with the filings. And then we'll have a second credentialed actuary that serves as a primary peer reviewer. And then what we also do is we get together as a group so we can discuss all the market-wide and nationwide issues amongst ourselves, just to make sure that all of the insurers in DC are addressing everything that should be taken into consideration. You know, and so what are some of those things that need to be considered? Well, there's quite a few rate increase drivers each year. There's kind of just the annual claims cost trend, or the inflation, just the cost of services going up each year. There's changes in the risk pool composition. Basically, that's the impact of new entrants, exiting consumers, the impact of consumers changing insurers, those kinds of things. One new thing this year was the American Rescue Plan. That changed some subsidies, which should introduce new people into the market, which should help put lower pressure on the rates. So that's taken into consideration. Some other drivers of rate changes are just changes in administrative costs. If the benefit package changes, that will change the rates. And of course, COVID, the pandemic, is still ongoing. There's still some expectation that it could impact rates in 2022. There could be some deferred costs. Delayed care could worsen someone's condition. There's the cost of actually, providing tests and booster shots and things like that. So those are all taken into consideration. So I'll now kind of segue into a few of the observations and findings we made on each of the specific carriers. The first one I'll get into is Care First, the Blue Cross plan. There's two separate entities that files rates in DC, and both of those entities file in the small group and individual markets. So for all four filings, we recommended a reduction to the trend based on a deferred care trend assumption. We thought it was too conservative. Other changes include we had the company, we discussed the exchange assessment fee, which was a little bit less than what the carrier had assumed, and that assumption actually flows through to all the carriers. For Care First, we also recommended revising risk adjustment, and what risk adjustment is the assumption to help balance that let's say the insurers with the sicker population get enough funds to pay for their care, and the healthier insurers don't get to keep all the quote unquote extra money from their premiums. So we made a revision to the risk adjustment. And then some other changes were to the contribution to reserve, or the risk margin assumption. There's an interesting dynamic in DC, as I mentioned earlier, with the merged market, and that can cause some differences between the HMO and the PPO premiums. And so that was taken into consideration. And so after all of these adjustments, the proposed rate change would decrease by 2.7% for the Care First individual HMO, and 0.8 to 0.9% for the other carriers. And it is for the other Care First filings. And so it is our understanding that Care First has agreed to make these changes. For United, they also have multiple entities. They have 3 entities in the small group market. I mentioned the exchange user fee reduction earlier. They've also have revised, based on our review, the trend assumption down by 0.5 percentage point. They have removed a risk charge for uncollected premium, which reduced it about 1%. And they also had some updates to risk adjustment based on some updated data. After those adjustments, the rate change would decrease by approximately 5% for each entity. And it is our understanding that United has agreed to those changes as well. For Aetna, there's 2 carriers. They have a PPO and an HMO, 2 different filings there. For Aetna Health, the filed rate decrease was 2.1%. For that, again, there were some risk adjustment modifications. Trend was reduced, the exchange user fee again. After those adjustments, the rate change would be a decrease of negative 5.1%. For Aetna Life Insurance Company, the filed increase was 23.4%. We recommended the same changes as we did for the HMO, but we also had a couple more we asked them to modify their statistical credibility formula. It's kind of how they blended the various data they had. And then we had them reduce the demographic factor applied to the DC experience. So after all those adjustments, that in a life rates would be a rate increase of 9.9, down from the 23.4. And then the last company is Kaiser. Kaiser is a little bit different. If any of you guys have been on this the last couple of years, you'll know that Kaiser has historically proposed rates that we have considered inadequate. We do think they are lower than they really should be. And so because of that, we do not recommend any further rate concessions or modifications to their rates. We did note that this year, the magnitude of the inadequacy had been increased over the last couple of years. So we do have the recommendation to the DISB to take that into consideration. Solvency is a key consumer protection. So we do think Kaiser has reasonably demonstrated that they do not pose a solvency risk to the consumers in the district. So we're not recommending any changes there, but we do continue to stress that the department should kind of keep that in mind as they engage in other regulatory activities in addition to just this rate filing. So Commissioner, that is the end of my prepared comments that I wanted to go over.
Excellent. Thank you, Dave, for your comments. Phil, am I at liberty to ask any questions?
Feel free.
Excellent. So just a couple of questions for you, Dave. You mentioned that L&E works with a number of states, and so I'm just curious to know what you and your team do to keep up with the changes that are happening related to healthcare reform.
Yeah, it really is beneficial that we do work with those other states because when I first started doing rate reviews, every state said, "Well, we're different from everyone else," and I don't know if I necessarily believe there would be 51 different stories, but it does kind of seem that way. So it is good to kind of know what the other states are doing, and then we'll take that and apply it to DC and what's applicable. As I said, DC is a little different, but so we do get to see what all the other insurers and all those other states are submitting. So that kind of helps the discussion to see, for the underlying assumptions for what the DC insurers have done. We also stay kind of on top of things just through industry meetings. I'm on the American Academy of Actuaries committee that puts out a white paper every year. I think it just came out this week about the impacts and what's going to help drive rates for the next year. So I'm involved with that process. I'm also on the board of the Society of Actuaries, and as part of that role, I'm involved with the Society of Actuaries healthcare cost model group that helps assess how things are changing with COVID and things like that.
Excellent. Thank you for your response to that question. Another question, and I'm sure it's front of mind for a number of folks as we are still currently in the pandemic. COVID-19 is obviously continuing to be a very important health insurance issue this year and most likely next year as well. Can you describe how the insurers approach the pandemic and their filings and how that compared to other jurisdictions?
Yeah, so obviously the pandemic is a massive uncertainty, and there's a lot of risk, and the insurers have had a wide range of experiences with it. Some insurers maybe came out favorably well during 2020, while others did not. And so we have seen a wide range of results, and we definitely see variations by state. There's been a lot of different restrictions and limitations in areas, right? So I live in Texas. We're kind of the wild, wild west. We've been kind of free and, do we even have a pandemic, right? So how the insurers are impacted in Texas is different than like in DC, which has had, a little more restrictions and requirements. And so now part of that though, it's great to have the restrictions, but you do need to think through how that might impact, right? So if there's certain restrictions, people aren't going out as much, there could be deferred care that could be carried on. Maybe there's that knee surgery, you're going to hold off on it, right? And you're going to wait. And we are seeing deferral care. And with the new Delta variant, we kind of thought maybe we were past it a little bit. People were going back to the doctors, things like that. But now with the Delta variant, there is potential for additional deferred care, people not going in 2021, and it could kick into 2022. So what we have seen, as I said, we've seen a wide range across a lot of insurers, but generally speaking, COVID has been expected to be about up to a 6% impact or a load. Some carriers have assumed no impact in 2022. Other carriers have assumed up to 6%, and DC was pretty consistent with the carriers in DC were pretty consistent with what we saw nationwide and within that range.
Excellent. A little bit just in still looking at some of the other jurisdictions. You mentioned that health insurance trend is one of the key drivers of a rate increase every year. Can you describe how the file trends in the district compare to other jurisdictions?
Sure. So trend is really, I mentioned the inflationary piece, and in reality, claims cost trend is really two pieces. And it's comprised of what we call utilization trend, right? So it's how often you're using those MRIs, going to the doctor. And so there's typically utilization trend each year. And then there is that kind of cost per service trend or that inflation trend. In the aggregate, those two pieces generally run from 2 to 8% a year. So, even if you have, $100 premium this year, you can kind of expect next year it's going to be around $105, $108 just by the increase by that trend. So when we reviewed the trend assumptions for the DC carriers, as I mentioned earlier, we did make a couple recommendations to knock it down a little bit. But we did not think they were necessarily, very out of whack versus what we see in other jurisdictions. So other than the specific things that we asked for reductions, it was very consistent with what we see elsewhere.
Okay, that's helpful to know. I think I have at least one or two more questions, if you don't mind. You mentioned that the district is unique in having a semi-merged market. Could you go into more detail about what the impact of this program is on the district's consumers and insurers?
Yeah, so this is kind of a tricky issue, and I'll try to make it as simple as possible. Risk adjustment, which I mentioned earlier, is one of the nastiest formulas you've ever seen in your life. It's a very in-depth formula based on claims of an insurance company. It's based on an assessment of how healthy or sick an insurer is. And as I mentioned earlier, if a company just happens to have very healthy people, they don't get to keep all that extra premium. Well, and so it's very complex to figure out which carrier owes what other carrier money and that kind of thing. Well, DC has a merged market, and so that semi-merged market, and so what that means is the individual and small group experience is merged together to help stabilize premiums in the individual market. The individual market is small versus the small group market. It's probably 20% of the size. And so in DC, the claims of both the individual consumers and the small group consumers are combined to help stabilize it, because the individual market kind of bounces around a little bit because it's so small. Well, the dynamic though is risk adjustment is not merged. And so I won't necessarily go into, again, all the details there, but it does create some differences in DC versus other states. And so what that means is for a carrier that participates in both the individual and small group market, their rates may be a little disadvantaged in the small group market because that individual market is blended in with it. Typically, the individual market is a little sicker than the small group market. So there is a little bit of a disconnect in DC because you have you have United and Aetna that participate in the small group market, but they do not participate in the individual market. And then you have Kaiser and Care First that participate in both. So there's a little bit of disconnect in the small group rates between those carriers because of the quasi semi-merged market.
Excellent. Thank you for responding to that question. And I think that'll be helpful just as we talk more about the difference in the markets, but also in the rates. So thank you for that. And this is my last question. This question really speaks to the differences in the recommendations between the two actuarial firms, one being yours, Lewis and Ellis, and also in Oliver Wyman. So some of L&E's recommendations are different than those recommendations made by the Health Benefit Exchange actuaries, Oliver Wyman. Have you reviewed Oliver Wyman's recommendations? That's my first question. And second, do you believe any of the differences between the recommendations are material?
Yeah, so we have reviewed, my team has reviewed all of the Oliver Wyman filings, and there are a few minor differences, and I will say I do think they are minor. You know, anytime that, you know, you have different sets of actuaries looking at things, I would say there can be a range of reasonableness where two different answers aren't that materially different, but they're both considered reasonable. You know, very simplistically, maybe I say 4.9 and they say 5.1, that we would not consider material. And I do think, but I wouldn't say they were wrong, and I doubt they would say we were wrong. It's just, you know, two different reasonable answers. So as we look through it, I think that's, you know, the differences are chalked up to that. And so we do not have any concerns about really digging in and having to worry about any of those differences.
Excellent. Well, thank you for your response to all of my questions and for your comments today. And we'll be hearing more from the Health Benefit Exchange next, which hopefully will also expand upon some of those differences in the recommendations that both actuarial firms have presented. So again, thank you, Dave.
Thank you.
So next,
Appreciate it.
welcome. So next we will hear from Mary Beth Sinkowitz, Associate General Counsel at the DC Health Benefit Exchange Authority. Welcome, Mary Beth.
Thank you, Commissioner. I will share my screen here and get us moving. Okay. Is it sharing? Good. Thank you, Madam Chair. As you noted, I'm Mary Beth Sinkowitz, Associate General Counsel. I also happen to be the contract administrator for the DISB rate review process and supervise Oliver Wyman in that rate review. We appreciate very much, Commissioner Woods, your support for the Health Benefit Exchange since your commissionerhood, and your contributions as a board member, and most particularly the recent service on our Health Disparities Working Group. We really do appreciate you there, and we do appreciate your consideration of our recommendations. DC HealthLink is a public-private partnership, and as you noted, the online marketplace for residents and small businesses. We are able to, through transparency, market competition, and the simplification of the purchase of insurance, provide residents and businesses the type of market power only larger players had in the past. And as we have done over the years, we advocate for the lowest possible rates for our residents and small businesses. As you have noted, we have been working from the very beginning. You noted that we do have over about 100,000 people in our shop market, 80,000 from our small businesses and 11,000 members of Congress. They generate annually $520 million in premiums. And then we have approximately 15 to 20,000 residents at any particular time in the individual coverage, paying over 100 million annually in premiums. And as you noted, we are number 2 in the nation with a 96% of our residents covered. We do advocate for the lowest possible rates. Our actuaries, as you noted, Oliver Wyman, do provide our analysis and policy reasons. They work through the filings to identify unsupported assumptions and errors and work with the other actuaries. This year, Commissioner Woods, we really have two main policy recommendations that we would like you to consider. As Mr. Dillon noted, all of the carriers are allowing for this a COVID factor. And we have arguments that I will present to disallow that COVID factor because the assumption was that 22 utilization would revert to pre-COVID utilization. Now, we also would like you to consider to disallow the risk and profit factor, also called contribution to reserves and surplus, during this ongoing economic impact of COVID on employers and residents. So these are our recommendations in the individual side. As Mr. Dillon noted, and I would agree that the actuarial adjustments do center on trend, the exchange fee and risk adjustment, as Mr. Dillon recommended. And yes, they said those have been presented to your staff. So for the Care First HMO with the policy recommendation, and this is disallowing COVID and profit and the profit margin, we recommend a minus 1.3%. And for the Care First PPO, a minus 4.7% with all of the policy considerations taken into account. As with Lewis and Alice, we do not recommend any adjustments to the Kaiser filing. And then on the small group side, we are recommending for the Care First HMO a minus 3.3%. For the PPO, not to exceed 1.6. Kaiser to approve as proposed. The Aetna HMO, minus 13.2. The Aetna PPO, not to exceed 7.7. United Optimum, not to exceed 2.1. And then for the United PPO and Mid-Atlantic HMO, not to exceed 6.2. And I just note that we are using the terminology not to exceed when there is a rate increase versus the specific number when it's a decrease that we are recommending. So let's discuss a little bit about this COVID factor and perhaps why DISB should disallow it. Their proposed rates assume that basically 2022 would be returning to normal in terms of utilization, pre-COVID medical care. And as Mr. Dillon noted, the range is fairly high. It's 4.7 to 6%. So without that factor, the proposed rates would be much, much lower. And the assumptions that they had in the spring, and they filed this in the spring, things were looking pretty good in the spring. The vaccines had become widely available in the United States and in many parts of the world. The virus was not mutating broadly in the United States at that time. People were getting vaccinations. The shots in the arms were going pretty high. The lockdowns, the mask mandates, other restrictions were being lifted. Infection rates were going down. Deaths were going down. Hospitalization was going down. People were beginning to get non-COVID medical care and procedures. And it looked like the pandemic may be coming to an end. However, we all listen to the news. We all know that information from the spring is no longer accurate. The Delta variant has spread rapidly in the US. We now know that vaccinated people are going to need a booster shot after 6 to 8 months because it becomes less effective. We now know that vaccinated people can spread the virus and get COVID, these breakthrough cases that are becoming, we see more and more of. In the US, 75% of adults, not the entire population of adults, are partially or fully vaccinated, 64.3 fully, but experts tell us that for the Delta variant to reach herd immunity, 80 to 90% of the population, entire population, needs to be fully vaccinated. Unfortunately, only 27.9% of the world population is vaccinated. We know that the virus mutates and spreads in these unvaccinated environments and crosses state and international borders. Mask and other COVID restrictions are being reinstated, and hospitals are reinstating restrictions on care. Some examples show that nationally, 1 in 5 ICUs have reached or exceeded 95% of bed occupancy. We now see stories emerging about non-COVID hospital surgeries being impacted. We cited a story about a breast cancer patient that literally needs medically necessary surgery now and is going to have to wait weeks to get that surgery. We read about a child being airlifted 150 miles because the local hospitals are at a capacity with COVID. Things gotten so bad in Orlando that the water utility is making an urgent appeal for residents to cut back on water use sharply because the pandemic triggered shortage of liquid oxygen, which is needed to purify the water, is needed for their COVID patients. And as an example of hospitals restricting patients, MedStar Health is now only allowing 1 weekly visit if a patient is expected to stay at least 3 weeks. In DC, our vaccination rates are 57.84 fully vaccinated, 67.4 partially or fully, but 32.6% unvaccinated. But with these numbers, we rank 13 out of 51 by percentage of population vaccinated. So we are near the top. As I've noted, the Delta variant, it has no borders. It has spread quickly. The district's new daily case rate has risen from 1 to 29, according to the Mayo State Tracker. On July 8th, the daily average was 1.0, and on September 7th, the daily average was 29 per 100,000 people, an enormous spike. And as we all know and can see, DC has reinstituted a mask requirement for indoors for all, regardless of your vaccination status. Dr. Anthony Fauci appeared on the Today Show recently, noting that 80 to 90 million Americans need to be vaccinated. And he was asked a question about when we'd be getting out of this pandemic. And he said, you know, it's going to depend on us. It really is. It's in our hands. Our fate is in our own hands. It probably will be, you know, I've said a couple of times, if we do it right and get through the winter, I hope as we get to the spring of 2022, we'll be there. I hope so. It's up to us. So the nation's foremost expert is not predicting that starting in January 22, we'll be back to normal. If we do all the right things, he is predicting the spring of 22. Well, I hope that 80 to 90 million people get vaccinated. So in the spring of next year, things are back to normal. But unfortunately, current evidence shows that to date, collectively, as a society, we're not successful at doing the right things. Therefore, the current data does not support the assumption carriers made when they filed their proposed rates in May of 22 that utilization would be normal and revert to pre-COVID type utilization. Therefore, we urge that DISB disallow the COVID factor that ranges from 4.7% to 6% in the proposed rates. We also believe DISB should disallow the risk of profit factor, also called contribution to excess reserves and surplus, that are proposed. Residents and employers continue to experience the severe negative economic impact of COVID. This slide will show you that our carriers are in very good financial condition. Risk-based capital, very technical term, but we in this industry know what that means. And what this chart shows us is that everyone has a risk-based capital well over 200%, which is the number that would trigger corrective action. And in fact, as you can see, we've got some in the 600s and the 500, you know, and even one over 1,000. So the carriers have a very sound financial condition. We still have our residents are still, and employers are continuing to experience these negative impacts. The unemployment rate is still high. While it has come down, the July 2021 unemployment rate in DC was 6.7%. And their wage growth has slowed dramatically. In FY19, wage growth was 4.6%. And in FY20, it went down to 1.8%. And the projected FY21 wage growth is 2.8%. So while some employers are doing better, the recovery is uneven. Looking at the employers with past due premiums for SHOP, Of the 5,200 plus employers now covered, 442 are in arrears or 7 million. In July, we had 768 employers in arrears for 10.4. Last October, we had 844 employers in arrears in 1 month. Pre-COVID, normally we had 50 to 70 groups each month in arrears. So the numbers are promising, showing that some employers are recovering, but it is clear that many employers continue to experience the negative economic impact of COVID-19. And let's look at some specific businesses important to the district. The accommodation and food services GDP is at the end of Q1 21 at 4 billion, from a low of 3 billion at the end of Q2 20, but still well below the pre-pandemic high of 6 billion. And the leisure and hospitality employment dropped sharply from 82,000 in February 20 to 31,000 in April 20. It has grown gradually since then, to be 49,000 as of July 21, but still far below the pre-pandemic number. And GDP at the end of Q1 21 is a negative 0.3%. And as we all know, our Black and Brown communities have been hit hardest by COVID-19. 76% of the deaths in DC are Black African American residents, but those residents are only 46% of our population. But the Biden administration, through its American Rescue Plan, does assume a challenging road to economic recovery. It provides relief for states and cities for 21, 22, 23, and 24. Also, local leaders recognize that residents and employers in the district have not fully recovered, and many continue to experience economic hardships. The mayor and council put in place relief programs to help residents and employers in 21 and 22, such as rental assistance, free financial navigators, and the use of family medical leave for quarantine. So people are still struggling to afford food and rent. Businesses are still struggling. However, despite the fact that businesses are struggling, employers are still prioritizing having health insurance. Some employers even furloughed their workers, but kept their health plans. In the time of crisis, we do want to note all of our health plans have acted in unprecedented ways to help. Our health carriers have really stood up to the plate. Free telemedicine, free COVID treatment, accelerated provider payments to premium relief. The health plans have taken concrete actions to help their members and the community. The response by residents, businesses, policymakers, providers, health plans, our entire community to the unimaginable economic and human toll of COVID-19 shows that we really are all in this together. And unfortunately, it's not over. In summary, these again are a summary of the recommendations that we have made for both actuarial and policy reasons. And in conclusion, Commissioner Woods, we want to thank you for holding this hearing, for considering our recommendations, and for your leadership and work to protect insurance consumers. Thank you.
Thank you, Mary Beth, for your presentation. You've definitely given us all a lot to think about, so thank you. In terms of questions, Phil, are we posing questions or moving on to public witnesses?
If you have questions, I think you can ask those now.
Okay.
I'm trying to unshare my screen. Is it still sharing?
Yes.
Okay, sorry about that, Commissioner. I'll try to continue unsharing it, but if you have a question, I can do that at the same time. I'm having an issue. There we go. Something happened. Okay, see if that works. Is that better?
Yes,
Yep.
that works.
Thank you. Sorry about that. I'm not very proficient at these things. That was my first try. Thank you.
Great. I think the only main question that I have is a similar question that I posed to the previous witness Dave, Dylan. And so wanted to get a sense from you, and you may or may not have the answer to this question, but have you reviewed L&E's recommendations, and do you believe any of the differences between the recommendations are material?
Unfortunately, Commissioner, I have not reviewed them. No, the short answer is no, I have not. Our actuaries, I have shared those recommendations, but we haven't seen theirs specifically, although from Mr. Dillon's testimony, it does seem that we were close on many of the issues. I mean, he mentioned the same things we did, the trend, the exchange fee. We would be happy to have normally our actuaries do kind of sit together with Lewis and Ellis and try to do this. The process was a little bit different this year for a variety of reasons. But we'd be happy to, whatever you would like, Commissioner Woods, we'd be happy to sit with Lewis and Ellis actuaries to discuss those, to see if there are any real material differences that we could agree on.
Okay, great, thank you. And there's possibility our teams may be definitely following up with the
Yes,
actuaries on that, so thank you.
that'd be great.
Excellent. So I don't have any additional questions at this time.
We did get, Mary Beth, we did get a couple of requests for your presentation. Do you know if you're going to post it on your website or anything?
Yes, I believe we will. I'm relatively certain that will be posted. Yes, I will. I'll let you know where and when.
Okay.
Thank you, Commissioner.
Great, thank you, Mary Beth. So moving on our agenda, next we have a list of public witnesses that we want to hear from. So as I mentioned in my comments, we will go through the list that we currently have, and if there are any additional witnesses that would like to testify, please put your name in the chat, and we will call on you after we've gone through our list of witnesses. So our first public witness is Bhavna Lee. Is Bhavna Lee with us? Again, Bhavna Lee. Okay, moving on. Our second witness is Wendy Williamson. Is Wendy with us?
I know Wendy, I can see Wendy's here. She's here.
Hello, good evening. Thank you for hosting and having this hearing as you do every year. So I really appreciate it, and I appreciate the chance to offer testimony as well as hear from my fellow DC residents on their stories and struggles. Right now, I work for a company that does not provide insurance. I pay out of pocket. So I pay the Care First PPO, the Bronze plan for the HSA, because I'm trying to do it. I know I'm going to end up spending the money, so I might as well get a tax credit for it. So currently, I pay $552 a month. And the maximum HSA for me is $3,600. And I've already maxed out this year because I'm sure, like my fellow residents can attest, all the screen time at home has made my vision change. So I had to get new glasses. And I guess I clenched my teeth in my sleep from stress. So I had to get a couple crowns. So all that being said, by the end of the year, I will have spent close to $20,000 because my health insurance for the year is about $6,600. On my HSA account is $3,600. And my primary care doctor has gone to a concierge service, which means it's going to be very difficult to find a new doctor that knows you during a pandemic. So I've had to pay for a concierge doctor. And this health insurance doesn't provide dental or vision. So I've also had to outlay extra funds for dental as well as vision. Now these costs don't include transportation to and from these appointments. And I have other doctor's appointments coming up. So of course, some of these charges have to go on credit cards with interest rates varying from 12 to 14%. That can't always be paid off at the end of every month. And additionally, just looking at the figures of the proposed increases, my Care First PPO, let's just say $771, which is what it's listed on the proposed sheet. That's a difference of close to 40% increase. That's pretty big considering the rate of inflation is less than 10%. And according to the woman who just spoke, Care First PPO is doing pretty well. So I would just appreciate that the next time someone goes to, buy a car, or go to school for tuition, that's the cost of or close to it, my cost to be healthy. I looked up a 2016 Toyota Corolla costs about $16,000. Well, my health insurance costs more than a car. So, it's just very frustrating that, insurance to be healthy costs money. And I know I say this every year, so I appreciate the opportunity to just reiterate that any sort of decrease is more money that I can put into the slow economy or in a possible retirement fund. Anything extra is just money that is not going anywhere except to an insurance carrier. So again, I thank you for the opportunity. And again, that's my status. Vaccinated status, I should say.
Well, thank you, Wendy, for sharing your status and your testimony with us today. Any questions?
No, but I will say that Wendy is probably our most consistent speaker. I think she's probably spoken at every rate hearing we've had.
Well, great. Thank you, Wendy, for your consistency.
Thank you. And when it comes to money, I'm all in.
Absolutely. So our next public witness that we have is Sarah Bever. Is Sarah with us? Again, Sarah Bever.
And I believe I saw her, so let's give her a second to see if she is.
Can you hear me now?
Yes.
Oh, good. Oh, I don't know if my video came on as well, I think. Anyway, thank you so much. Although in the past I have testified about our DC rates versus national rates and healthcare statistics, today I'm speaking about special costs that surprisingly DC levies on insurance companies. This is based on my personal experience, and I hope I offer a simple practice that could result in savings ultimately to the consumer. DC HealthLink Benefits Exchange tells Care First what my adjusted monthly premium due should be. Then Care First sends the invoice. During May's special open window, I changed plans within Care First. And due to some kind of misunderstanding on the telephone with the Health Benefits Exchange case manager, I found out near the end of May that all of my coverage had been terminated retroactively to the end of April, and I had no coverage. It has taken 4 months of paperwork, telephone calls, and the DC Insurance Commission, DISB, to help me and Care First in straightening out this simple plan change. I have received 9 separate invoices for June. And remember, Care First only sends these based on the Health Benefits Exchange direction. These June invoices reflect conflicting totals due from $0 to over $1,000. My last received for June is dated August 30th. So I don't even know that I'm finished receiving invoices for June. It seems that the Health Benefits Exchange caused Care First to re-enter my account, I don't know, maybe 9 times. It seems like this ultimately became some kind of data processing nightmare, both at the Health Benefits Exchange, which then cranks out data that gets transferred over to Care First, and then that triggered them, I guess, into some data processing nightmare where they had to keep recreating my account. And it was always some error that then had to go back to the beginning of the whole data processing process. I guess, I don't know how this could have taken so long. But the simple error at HealthLink Benefits Exchange has cost Care First for 4 months. And forget what it's cost me and DISB. HealthLink Benefits Exchange must enable a mechanism such as maybe something as simple as a confirmation email before enacting on a presumed plan termination, especially a retroactive termination. Let me repeat, a simple confirmation email before terminating. This sprang from a phone call with the case manager at Health Benefits, and she was off and running with whatever. I don't even know what to say. Anyway, a Health Benefits Exchange error such as this one ends up costing Care First and others a lot. How many other consumers have been subject to such simple yet costly errors? And if such errors didn't happen, Care First's expenses would be reduced, which means they could charge consumers less. So thank you. That's my testimony.
Thank you, Sarah, for your testimony. And I know we have a number of representatives on the call from the DC HealthLink, and I'm also pleased to hear that my team has been helpful as well in some of your inquiries. There might be some follow-up that we'll conduct after the hearing. So thank you for your testimony.
Thank you.
Great. Our next public witness is Barbara Kittredge. Is Barbara with us today?
Yes, I am. Thank you very much for the opportunity to testify today. I'd like to put this in the context of some personal changes that occurred to me, but also in the greater context of what I see that's going on in the insurance industry. Clearly, our pricing needs to be linked to more, I would say, varied information that looks at the profit trends for each of the companies that are bidding for our business, MLR, and credit ratio worthiness of the individual insurers. Let me throw out a couple statistics. This is all full year 2020 profit margins for a number of the nation's largest insurers. United Health Group, its full year 2020 profit was $15.4 billion. Humana, which actually had a rough year last year, their full year profit was $4.6 billion, which was actually a 40% increase over the 2019 period. Cigna reported a $4.1 billion in profit for the fourth quarter, but their full year profits were up $8.5 billion, a 66% increase from the company's profits of the prior year of $5.1 billion. It's clear that health insurance continues to be big money. Most of the companies tend to, increase their profits year on year, and in general, during 2020 and COVID, they have benefited from the fact that most individuals had put off their urgent care. And what we're seeing is that many Americans have delayed elective and other non-emergency care. And that's actually consistent across all of the different consumer segments, the individual markets, group markets, Medicare Advantage, Medicaid Advantage. And I think the challenge becomes that in the context of the continued profitability and the continued health of the balance sheets of these companies, the price increases are being passed on to us, the consumers. Just to give you an example, unfortunately, I was laid off beginning in January of 2021. My prior employer provided healthcare was $289 a month that I paid. I am now paying, with the DC healthcare plan, $1,035.79. That's only for me as an individual plan. It's clear that I also have a challenge where, because of a lack of competition in the marketplace, where I only had 2 individual opportunities between Blue Choice or Kaiser to pick plans, that there wasn't significant competition for me as a consumer, which then increases pricing opportunity, increases price to me as a consumer. Put that all in the context of when I finally was able to get back to work, I actually had a 47% decrease in my annual income. However, recognizing that, health insurance is a significant requirement, I'm now spending a much higher portion of a lower salary to cover my healthcare costs just as an individual. Now, I can make that work. I don't know how families in the DC area can actually, sustain these kind of increases. And it's certainly significant that, particularly during a time period of unemployment and when people are changing insurers and perhaps coming off of company-owned plans going into individual plans, that actually they see a marked increase. I'm lucky enough that I'm able to manage through these cost increases, but it still is a significant hit on my pocketbook. And I think it's likely that if you look at it in the context of profitability trends and MOR, medical loss ratio, and the creditworthiness of these companies, they are still doing very well financially and are passing on those costs, even as we go into a year that was 2020, which was driven by COVID. They are not taking the kind of hits that we should expect to be passed on to end consumers. Thank you very much. I appreciate the opportunity to testify today.
And thank you, Barbara, for your testimony. Questions? Moving on to our next public witness, is Heather Jameson on the call.
Hi, yes, I am.
Hi, Heather.
Hi,
Feel
thank you.
Great.
I am self-employed and have been self-employed for about 10 years. And I have purchased my health insurance through the exchange since the beginning, after the Affordable Care Act took effect. I am a cancer survivor of more than 20 years. So I am, even more reluctant than under other circumstances to give up my insurance. But the rates have doubled, at least for the premiums, since I started getting my health care through the exchange. And I'm a big supporter of the exchange, and I love the concept, but it's expensive. My income has not doubled in the past several years, but my health insurance premiums have. I switched to a bronze plan for this year. I applied for some financial support from the American Rescue Plan, which I received, so I'm very appreciative of that. So I just, want to share this as the perspective of, a small business person, sole proprietor, that the rates are difficult to absorb, and the high deductible plans that, just sort of, it makes it worse. With the increase in the number of, so-called gig workers nationwide, I think, this is going to become a bigger issue for more and more people, that they are responsible for purchasing health insurance on their own, that they don't have it through their employer. So just given, sort of the economic trends in that regard, I think, that poses a challenge for DC if our uninsured rates go up as a result of that, and more people finding work as individuals instead of employees. That's my testimony. Thank you.
Thank you, Heather, for sharing your perspective with us today. Our next public witness is Aditya Dahagam. Is Aditya with us?
Yes. Hi, everybody.
Hello.
Hi. Thanks for inviting me. I appreciate the opportunity to talk. I'll try to keep it short because everybody else has said a lot of great things here, and I really appreciate the presentations from the actuary and the general counsel. And kind of giving that transparency, or trying to give us on why the rates are increasing. So I'm a small business owner here in DC, have been for 10 years, and we've been on the exchange for almost since it started. And it's really been great for us in the sense that it's giving a really good pricing, not only for our DC-based colleagues, but also our out-of-state colleagues. There's people we've hired who, because we're a DC-based company, they have access to exchange where their states actually denied a lot of the expansion of the ACA, right? The benefits of that. So they're definitely appreciative of that, and we are of that. But the rate increases, of course, are questionable in my opinion, just because it doesn't seem justified. Right? Some of the transparency here that I'm not getting in some of the documentations and the artifacts that were posted before here, it doesn't tell me why. You know, what is it? Is it administrative costs? Are the price of drugs getting higher? Are the doctors raising their prices and therefore we need to pay for them? Like, what's the reason for it? And I think the other witness before me had mentioned, had talked about, you know, the profit margins of these companies and whatnot. And that's, you know, and obviously there seems to be some wiggle room from their end to say, hey, let's not increase it, especially during a pandemic. And I think it's also really important to realize that, you know, that the testimony from the general counsel about the COVID rate, the COVID upcharge that they're doing. I didn't know that, right? Why would they be able, why are they doing that when, if they are expecting 2022 to be a normal year? So those are the kinds of things that I'm kind of looking for to understand a little bit better before the rate increases are. I definitely don't think it should be happening as much unless it's something like, okay, the cost of COVID drugs or cost of, you know, getting the transportation here because of COVID and the supply chain and the issues that we're having there logistically. Okay, that's fine. I don't mind paying a little bit more here and there. However, we just don't know that. I think that's where it will give a lot of clarity to a lot of people if they could get that answers. But overall, I really appreciate the DC Health Exchange. And I actually have found myself very fortunate to be a DC resident and to live here, to have access to this, because a lot of other people in the country don't have it. So that's my testimony. Thank you for your time.
Thank you for your time and for sharing your testimony today. Our next public witness is David Hillison. Is David Hillison with us?
I am, and I turned my video on for you as well. I assume you can hear me all right?
Yes, thank you, David.
Pronunciation was spot on, so thank you for that, Commissioner Woods. I did give testimony last year, not like Wendy Williamson, who seems to be a celebrity, and I love that. I hope that in future years I can rise to that occasion. And you are going to hear, I'd like to repeat a little bit about what I shared last year, but I'm going to give you a touch of background, but you're going to hear a different type of testimony from me. And I certainly appreciate the things we've already heard, including from the actuarial team. I was a wholesaler in insurance for 26 years, started my own retail practice working directly with consumers in 2016. Didn't want to write health insurance because it's an area of dissatisfaction. And what I found is that people needed my help. And since then, I've installed or taken over 185 medical plans, including 45 last year and 42 the year before. So COVID during an active year, a lot of demand. In DC, I presented last year that I had just written my first case in DC. And after seeing the rate increases, I asked the team whether I had made a mistake, because I don't have any control over what happens downtown. But I could see with that level of rate increase that I was going to look bad. You know, ultimately, you're in a very strong position because in general, people don't have a lot of choice. But I can say from last year to this year, my DC business has grown by 200%. I now have 3 clients. All 3 of those small businesses pay for the health insurance at some level. One is in the restaurant business, and I think these things are relevant. One is in the restaurant business, one is in the business services industry, and one is a church. And one of the things that I am finding, two of them I installed, one of them, there was no agent. And ultimately they selected me simply because my last name started with an H. And how do I know? Because I asked them. And, you know, it's an unbelievable approach to selecting an advisor. But as you talk about rate increases and changes, having an advisor is certainly an important part of that process. But more important was simply understanding and navigating the framework of insurance. And even as I hear, you know, Sarah, you know, talk, there are a lot of things where an agent and broker can help navigate some of those things and, you know, certainly create some appropriate balance and perspective, which is, I think, what we all want, because we're all in it together. And I think that's sort of the general point. I've asked insurance companies to consider me a partner if they want me to think of them as a partner. And I think of you as a partner as well, as we try to provide solutions. So what I talked about last year was whether we need to limit the number of visits for people when they go to the doctor, right? Whether we need to tighten the networks and provide better networks and, you know, give people guidance on how to consume healthcare. And when I look at those Kaiser rates, you know, at 0.0 and minus 3.1, and hearing the actuaries say they want to charge, they think they should charge more, and here Kaiser is keeping it stable and charging less, I recognize that people give up some level of control, and ultimately that's what I'm talking about. So across the board, what I have seen from insurance companies this year are either flat rates or rates that have come down slightly with an increase in out-of-pocket limits. And so there hasn't been a lot of conversation here about pushing more of the burden onto the real consumers of healthcare. And I know that we do have consumers of healthcare here that provide testimony, and I appreciate that as well. But, you know, any rate increase that is above 5% seems to be off track from the general trend that I'm seeing for small business. Okay, so I saw 24% on there. Again, it just doesn't fit with everything else that I'm seeing. So I wanted to provide that perspective. I continue to think, as I work through my systems and think about the future, that I need to provide a better framework for wellness and more incentives around wellness, so that our focus is around living our best life and our healthiest life, and not how we divvy up the pennies. So I appreciate the opportunity to provide testimony, and I hope to be back again next year.
Well, thank you, David, and thank you for sharing your perspective. And I will say that I do remember you last year, and so good to see you again, and look forward to seeing you again next year. Thank you for your testimony. Our next public witness is Arun Mallikarjunan. Is Arun with us?
Yes, I'm here.
Welcome.
Yes, thank you. So, so my name is Arun Mallikarjunan, as you said, and I'm the CEO of Symbiosis. I'm going to give you a little bit of detailed introduction just to set the context, and you'll know why as I keep going. So I founded Symbiosis in 2017, and the goal for Symbiosis is to empower healthcare professionals to start and grow their practice. And we do that by providing with a practice in a box solution. So essentially everything operational is taken care of by us, so that the providers can focus on what they really like to do best, which is taking care of patients, right? So currently we serve about more than 30 practitioners across 18 clinics, most of them in the DC metro area. So one of the interesting things that I noticed as we grew is that more than 80% of the practitioners, right, in the clinics that we serve are either women or part of the minority. And most of the minority belong to the LGBTQ community. So that kind of showed me that we are opening doors for these underserved groups that were previously unattainable, right? So coming to my point about the testimony, the folks that start these healthcare practices are generally taking a huge risk, right, compared to somebody who's working for another company or a clinic rather. So until they grow to become self-sufficient and even profitable, they're taking a huge pay cut. They lose their employer-sponsored health insurance and among other things as well. Like, I mean, you heard from the lady who spoke before me. So Symbiosis itself is a startup, so we're facing some of the same issues that these practices face as well. So to provide some context, my wife, she runs her PT clinic, physical therapy clinic, inside the Symbiosis's doors. We are based in downtown DC. And because Symbiosis itself cannot afford to pay health insurance for me, I am having to get through insurance through my wife's clinic, and we pay about $1,000 per month towards health insurance for the three of us. So it's not just for Symbiosis that I'm speaking here, it's also for all the community that we serve that I'm testifying, right? So these rate increases hit all of us really hard when our margins are so thin already. It can really be the make or break decision for them when they're thinking of starting their practice. So some of the folks here, Aditya, and I can't remember the lady's name, but they're also and then Mr. Hillsborough. Yeah, so I think I got his name wrong. I'm apologize, but they're all small business owners, and I completely agree with all their points that this rate increase does not make sense. So, and I know for a fact that DC's always been about promoting entrepreneurship, and Symbiosis has definitely benefited from it. This action, though, is definitely going in the opposite direction. It's kind of pushing people away from stepping out and taking a risk and going out on their own. That's all I have to say. I really appreciate you guys giving me the opportunity. This definitely is something that I appreciate DC doing. So thank you so much.
And thank you, Arun, for sharing your perspective as a small business.
One thing that I just remembered, I just forgot. So let's say we give this testimony and then you take this into account and then come up with some proposals. Would there be another consideration so that gets proposed and say, hey, this is what we've come up with, and then the people get to hear it? Or whatever you hear and decide after this is final?
Pretty much the way the process works, and as I mentioned in my testimony, we will take all of the testimonies and comments into considerations and then make a final determination of the rates. And that information will be published on our website by the middle of this month on our website. So we won't have another public forum to discuss any changes to the rates. But again, we allow this forum so that we can hear from the public and take some of this into consideration as we work to finalize rates. So hopefully that answered your question.
Yeah, it did. Thank you.
Thank you. So our next public witness is Marcus Ross. Is Marcus Ross with us? Didn't see his name.
I know he was here earlier, but I don't see him currently, so.
Okay. So our next public witness is Lee Bethel. Is Lee Bethel with us?
Yes, I am. Good evening.
Yes, can you speak up, Lee? Oh, there you go.
Yes.
Great.
All right, how's that? A little bit better?
Yeah.
Perfect.
We're good? All right. Commissioner Woods, my name is Lee Bethel, and I'm a Washington, D.C. resident and president of Comprehensive Benefit Services, a Metro D.C. area employed benefits consulting firm. I've been a broker for over 40 years and a broker on DC Health Link since its beginning. I've also been involved in several DC Health Link working groups currently and in the past, and I currently serve as the chairperson of the DC Health Link Producer Advisory Committee. While I have a handful of individual health insurance clients, my major area of focus is the small group market. As a small group broker, one of my most challenging responsibilities is the annual renewal meeting with our groups. This is where we review the new renewal rates and assist the employer with determining their strategy for the renewal. My small group renewal rate experience, for the most part, has actually been pretty good. For the vast majority of our groups, our renewal rate increases for our reference plans have been manageable for the past several years. This is a renewal increase that we are able to renew without having to recommend that the employer make major changes in their reference plan and or their employer contributions. You all have heard several individuals talk about bronze plans today, and the reason they're talking about those bronze plans is that's kind of where you sometimes have to go to get something that is actually affordable. So while the premium is affordable, you have to put out a lot. You might have a $6,000 deductible to be in a bronze plan. So you're also having to pay premium, but you're also having to pay for most of your care. So those are challenges. Since we have a wide array of plan options for small groups in DC Health Link, we have been, for the most part, been able to find alternative plans that still meet the employer's goal of providing quality health care at reasonable rates for their employees. I understand that there needs to be a balance between the rates so that the insurance companies can obviously remain in business and that employers can continue being able to offer affordable benefits to their employees. This is especially true during the pandemic that we're now experiencing. It is important that we keep health insurance affordable for the citizens of businesses located in the District of Columbia. It is important to keep rate increases under control because over a number of years, the increases can be substantial. That was demonstrated by one of the witnesses earlier today who indicated that her premiums had doubled over the period of time that since she purchased her coverage. I have the wonderful job of telling the business owners that their health insurance is going to be their number 2 cost outside of payroll, and this cost has to be managed. So with that, based on the information that I've heard this evening from the testimony from the actuaries and also from the Health Benefits Exchange, the COVID statistics, the information that was presented through the Health Benefit Exchange with those decreases, I'm actually in favor of. I'm pleased to hear that there's a possibility of rates possibly going down somewhat rather than what they normally do and go up. So I heartily support that. I would also like to go on record to request that we try to add what we call a composite rate option to the age-based rating system that we currently have. This would allow the employer to choose which option would work best for them in providing coverage for their employees. It is time for that change to take place. The composite rate system provides a more predictable premium rate for both the insurance company and the employer. As a broker, we hate to show an employer what the rates are when they have an employee over age 50. If you had a chance to review the age ranges on some of the plans, you saw that the younger ages paid much less than the older ages. You have a mature workforce, your cost goes up exponentially. It's extremely high. When you look at the age rating system, you immediately see the discrimination in the rates for older employees. A composite rate system is a much more equitable way of premium structure. So having that kind of rate structure as an additional option so the employer could choose, I think would be a very good benefit in structuring the rates going in the future. I'd just like to end with, I thank Mila Kaufman and her team. They're doing a great job in managing DC Health Link. Obviously, they are not in control of the rates, but because insurance companies are doing that, but their system has been very well, the exchange has been very well run, and it's been a pleasure to be working with them as a broker. Thank you very much for this opportunity to provide you with my testimony.
And thank you, Lee Bethel, for sharing your perspective today. Our next public witness is Marianne Mikolaikas. Is Marianne with us? I didn't see her name in participants list. So no Marianne. We'll move on our list here. Our next public witness is Raina Miller. Is Raina Miller with us?
I didn't see her name either.
Okay, so moving on, our next public witness is Vicha Anissa. Is Vicha Anissa with us? Okay, moving on, our next public witness is Margarita Digon.
Hey,
Margarita with us?
Yes, I'm here.
Yes, great.
Okay, so I'm going to try to just highlight the most important parts. Honorable Commissioner Karima Woods, thank you for the opportunity to speak at this public hearing and to provide testimony on the ACA implementation in DC. Again, my name is Margarita DeLone. I'm President and CEO of Crystal Insurance Group. And in addition, I'm a board member of the Greater Washington Hispanic Chamber of Commerce and numerous other organizations in the District of Columbia. Today, I'm here speaking on behalf of myself, as well as the organizations that I've listed. I work with DC Health Link, enrolling individuals and families, as well as businesses in the community, in the District of Columbia, and some nonprofits. The longstanding mission of the ACA, as it relates to small businesses, was to level the playing field and provide small businesses and nonprofit access to plans that would allow them to compete with larger firms in the ability to provide competitive group plans, both in terms of rates and options. And DC has definitely done that. So basically for small businesses, it's about attracting and retaining employees. And now because of COVID, that is more important than ever right at this moment in time. I know a lot of businesses right now that are suffering because they're trying to attract employees. However, the rate increases are causing significant hardship to small businesses. One of the things that I can comment on is that the American Rescue Plan has helped individuals and families significantly. A lot of my customers have taken advantage of that. But when it comes to small business, there is not an equal footing there. And even though some of them did apply for PPP and other grants, they're having a struggle paying for their premiums. So the rate increases on the small business side are really hitting them hard. With expenses of COVID, income going down, you have rents that are still very high on the commercial sector for space, and that they are tied into leases that they can't get out of many times. So all these costs, and also still the cost for the Family Leave Act that the district imposed, all of those are hitting small businesses all at the same time. So it's a perfect storm. So the one thing that I would advocate for more than anything, and especially because most of the businesses that I write tend to be very small businesses, tend to be businesses owned by or serving communities of color, which is one of the communities that have been hardest hit. So what I'm going to say is that I'd really like to advocate to keeping those rates low for the small businesses, to trying to figure out ways that we can assist them. And also, the other thing is I understand that there's work being done on, for example, the diabetes medication. That's something that I really need to advocate for as well, because our communities of color have been harder hit with diabetes, with high blood pressure, and other types of illnesses of that type. I do have written testimony that is slightly longer, but I wanted to keep this short and sweet. I thank you. I want to thank more than anything DC Health Link and your office as well, Commissioner Woods, because frankly, you are one of the best run health exchanges in the country. And I appreciate the Bowser administration and everything that's being done for our small businesses and for our families. Thank you.
Thank you, Margarita, and thank you for your ongoing advocacy and participation. I know that you consistently participate in our hearings, and we thank you for your input today, and we'll definitely take it under consideration. You mentioned you had written testimony, so please make sure that you email that written testimony to the team so we have that on record. Our next public witness is Angela Franco. Is Angela Franco with us?
I'm here. Good evening.
Good evening.
Just give me a second, please. Excuse me. I'm getting my testimony. We'll send our testimony as well. Just give me 1 second. I apologize for this.
Problem?
Okay. So good evening, Commissioner Woods and members of the committee. My name is Angela Franco. I'm President and CEO of the DC Chamber of Commerce. We appreciate the opportunity to provide comments on the proposed 2022 health insurance rates for the health benefit plans on the DC Health Benefit Exchange, known as DC Health Link. As a continuing partner with DC Health Link, the DC Chamber represents over 1,000 member companies of all sizes and industries and the hundreds of thousands of individuals they employ. DC Health Link has the second lowest insurance rate in the nation. Nearly 97% of DC residents are covered, and the DC Chamber is committed to helping the remaining 3% get insured. The DC Health Benefit Exchange Authority removed financial barriers for COVID-19 and non-COVID-19 medical care and help residents and businesses get insured and stay insured. So I would say, I want to share a little bit of my experience working with businesses, but we are going through a difficult time in many fronts with a lot of uncertainty, and we don't believe that at this point is a moment to increase health insurance rates. People are struggling; there's still unemployment, and it can get even more expensive. DC Health Link has implemented several plans to really help residents get enrolled, or people that have lost their jobs get enrolled, and we applaud that very, very much. DC Health Link is also working with the health insurance carriers to ensure testing, visit associated with testing and treatment of COVID-19 that are all covered without deductibles or any out-of-pocket costs. The health visits are also covered with cost sharing. DC Health Link, and as we all know, I was part of the team before, and I know firsthand that they're extremely committed in creating programs that help individuals and businesses get educated and informed about the different options they have. We, as the Chamber, continues to partner with DC Health Link. We continue to conduct outreach and enrollment assistance, to working, building focus groups that can give us first-hand information on how better we can serve our business community. So at this point, I didn't want to go too long either, but we really want to say that this is not the time to increase rates. We encourage to keep the rates low and affordable for our business community. I thank you very much for the opportunity to testify, and I'm open to answer any questions you may have.
Thank you, Angela, for sharing your testimony with us today. At this time, I do not have any questions. No questions. This time, I don't have any questions. As you mentioned, you have a written testimony, and please submit that the testimony to our team so we can have that for our record.
Absolutely.
Great, thank you. Our next public witness is Aishi Patterson. Is Aishi Patterson with us?
Yes, I'm here.
Welcome.
Thank you. Good evening, Commissioner Woods and members of the committee. My name is Aishi Patterson Stewart, and I'm the Director of Operations and Administration at the Restaurant Association Metropolitan Washington, acronym RAMW. The Restaurant Association Metropolitan Washington actively promotes the Washington, D.C. area food service industry on behalf of our 1,300 plus members, which include restaurant owners and operators, food distributors, and service providers. Our membership soundly represents the diversification of the industry in the district. Established in 1920, RAMW is an advocate, resource, and community for our members. Before the pandemic, our local restaurant industry employed over 65,000 individuals, making our industry the second largest private employer in the district and accounted for 8% of employment in the city. In DC, 96% of full-service restaurants are independently operated, meaning a majority of local restaurants are small businesses. RAMW is also a small business, and like our members, we have found that the rates offered through the Health Benefit Exchange has made healthcare affordable to our team. I'm here today to testify on behalf of our local restaurant industry to ask that health insurance rates do not increase in 2022, as both employers and district resident employees continue to experience the severe negative economic impact of the COVID-19 pandemic. We are recommending to decrease rates, if not freeze them. RAMW has partnered with DC Health Benefit Exchange and has been enrolled in SHOP since 2014. Our partnership with HBX has been critical in keeping restaurants informed and aware of healthcare options that have been instituted due to the COVID-19 pandemic, including options for maintaining coverage for staff and options for staff who do not have employer-offered coverage. As the restaurant industry has dramatically been affected by the closures and needed mandates for public safety, many of our local district restaurants, which in pre-pandemic climates operate on razor-thin margins, continue to be faced with staffing challenges, which in turn affect operational capacity. Increased health insurance rates would be another added strain to a stretched thin industry that is still in the early stages of recovery. Local leaders recognize that businesses and residents in the district will be in need due to the health and economic impact of COVID-19 well into 2022 and have put relief programs in place to provide assistance. Currently, it is projected that the pandemic will continue to be a major factor in our lives at least into the spring of 2022. At this time, it is of utmost importance to continue to allow access to health coverage through low and affordable premiums during the economically vulnerable time for many. Thank you for this opportunity to share our testimony.
Thank you, Aishi, for sharing your testimony and bringing the perspective of RAMW. So thank you. And please make sure that you submit your written testimony for our records as well.
Will do.
So on my end, that's the last set of actual public witnesses that have reached out to be heard today. Do we have anyone else on the call who would like to testify but did not provide public comments in advance? And that would include anyone that is on the phone who has not submitted your name in the chat. Going once, going twice, last call for witnesses. Well, if anyone else is on the call and was not able to testify, as I mentioned in my comments earlier, we will continue to receive written comments up until September 15th. So please make sure that you submit your comments to our office. The email address is health.rate@.
Let's just.
We'll
let me
put it
make
in
sure
the
I got it.
chat
It's
so
in-
you
it's
can
in the
have it.
chat. It's in the chat already. I'm just going to go back.
Okay, great. So with that, I thank you all for your public testimony today. As I mentioned, we will continue to take all of what has been shared today into consideration as we are finalizing rates. And thank you to the DC Health Link for your testimony today, and also to Dave Dillon as well. And I'll turn things over to Phil Barlow to close us out.
Okay, so the email address, it's in the chat, but it's healthrate.comments@dc.gov. That was where you signed up for here and where you sent in your initial comments. So it's the same thing that you always had. And again, we will continue to monitor that. And thank everybody for your comments. We will take those under consideration as the department reviews the recommendations that we got from our actuaries, and as the commissioner said earlier, we will make a final determination on rates, work with the carriers to make any changes, and then get the rates approved hopefully by next week. And once the rates are approved, we will post information about them on our website, so you can look for that. You can also, if you have any questions, you can send those in through the healthrate.comments@dc.gov email address as well, as we are reviewing that, and we'll respond to any questions that come in through there. And I think that's it for this. So I think we can
Yes, I think that concludes our hearing today. And again, thank you for your time, and we will take everything under consideration. Enjoy your evening.
Thank you.